This one is a right-sided femur. If you keep it in anatomical position like this, so this will be right-sided and the head will be in the medial side articulating with the cerebellum like this. Here, so the neck is a portion. Next slide. Neck is a portion which connects the head with the body with trochanter, greater trochanter and lesser trochanter. Lesser trochanter is a posterior medial structure. You see, this is like this. So it is a posterior and medial. Medial structure, and greater trochanter is anterolateral structure. Anterolateral and posterior medial. G1 posterior. This is anterolateral. So this is the most prominent part of the bone posteriorly. This is called linea aspera. Very important because all muscles are attached to it. All muscles too. Next slide. So the structure of the head and neck of the femur is why it is important. The head and neck of the femur is for transmission. When we walk, stand, the weight of the body passes through the femur bone to tibia and leg. So from femur, how it goes? It goes through the head, neck, trochanter, then the shaft. What is the shaft? The shaft of the femur of this defined as it is 5 centimeter below the lesser trochanter. This is lesser trochanter. So 5 centimeter means 2 finger breadth below it. This is called shaft of the femur. Up to the flare of condyle. This is the flare of condyle. Flare of condyle means where the condyles are just widened, flare of condyle. This is called flare of condyle. So up to this much is called shaft of femur from below 2 inches. So this 5 centimeter portion is called subtrochanteric area. Subtrochanteric area. So trochanteric area, subtrochanteric area, shaft. Head, neck, trochanter, subtrochanter, shaft. And these are condyles. This is lateral condyle, this is medial condyle. Yes? So lateral condyle, medial condyle and lateral condyle. So if you keep it like this, you will see the lateral medial condyle is a bit lower than the lateral condyle. Next. So all the bones are composed of small struts of bones, struts, struts of bones, small fiber-like fibrils. These are called trabeculae. Trabeculae, there are 2 types of bone, you know. One is cancellous bone, one is cancellous bone is just called spongy bone. Another one is called trabecular bone or cortical bone. Cortical bone is hard bone. Femur is a cortical bone. Spongy bone. What is spongy bone? These are here the trabeculae are arranged in a loose pattern. But here the trabeculae are arranged in a tight pattern. So loose pattern, most important, the metaphyseal area of the bone. Metaphyseal, you know, a bone has got a epiphyseal area. Before the fusion of epiphysis, now it is fused epiphysis. The epiphyseal area, metaphyseal area, then physis. So metaphyseal area is a cancellous bone. And pure cancellous bone is, number 1 is a calcaneum. Calcaneum is a cancellous bone. So spongy bone and cortical bone. There are 2 types. So shaft and neck is also. You see how the trabeculae, there are 4 sets of trabeculae in case of neck. 4 sets. One is principal compressive group of trabeculae, principal tensile group, principal trabeculae. So this is called principal compressive group. This is going from the neck, medial side of the neck to the head. And principal tensile, this is coming from the greater trochanter towards the head. So this one is principal compressive force, this tensile. Second, greater trochanter is there, that side. So secondary compressive group is from this one to this side, and secondary tensile group is this side to this side. So this one is secondary tensile. So these are important because for if there is a fracture, when osteoporosis occurs, in old age, the osteoporosis occurs. So osteoporosis means bone becomes loosened, porous due to lack of calcium. This trabeculation is lost. First tensile group, then compressive group. Gradually, all the trabeculations are lost and the bones become weak. So anatomy of the neck connects the head with the shaft. This is head with shaft, this is neck. So it is 3.5 centimeter above long. Here, this is not 3 point, this is less. Because this is, I think it is a female body, female, so it is less. So it makes an angle with this neck shaft angle. This is attached to this one. This neck shaft angle, normally it is 127 to 135 degrees. 125 to 137. 35. 127, this one. And it is anteriorly, this is called anteriorly inclined. That is called the neck magna. This is a strengthened by femoral calcaneum bone, and that is a anteriorly also inclined. So this makes an angle of 130, it is written, but it may be 127 also, plus minus 10, means 125 to 130. So when the angle is less, it is called varus. When the angle is more, it is called valgus. Valgus. Valgus means like this. Valgus. This is varus. Valgus. Adduction. This is adduction. This is abduction. You know abduction, adduction, that not, I think. So away from the midline, abduction. This is adduction. Yeah. So valgus. So like that, there is rotation. Like this is called rotation, external rotation. This is internal rotation. This is internal rotation. This is external rotation. So valgus and so this calcar femoral bone. Calcar femoral means this portion is called calcar femoral. This portion, medial side called calcar femoral. Calcar femoral is very strong part because there is a principle. The calcar femoral is this trabeculation. So this trabeculation, this is principal compressive group goes from calcar femoral and secondary compressive. Principal compressive and secondary compressive. Both the compressive group goes from the calcar femoral, which is strongest part of the neck. And if it is broken, then it will be very difficult for union. And in osteoporosis doesn't occur. Osteoporosis are again about two types. It may be senile osteoporosis, means a person becoming old, the bone becomes porous. So osteoporosis. Even in ladies, when hormone is withdrawn, estrogen hormone, after menopause, osteoporosis occurs. It is called post-menopausal osteoporosis. Post-menopausal osteoporosis and senile osteoporosis. Senile means old. Senility means old. So old osteoporosis and senile post-menopausal. Post-menopausal osteoporosis is due to withdrawal of hormones. And there is another type of osteoporosis that is called drug-induced osteoporosis. So if a patient has got hyperthyroidism or getting some corticosteroid hormones, bone becomes, parathyroid hormone is more hyperparathyroidism. So these causes again osteoporosis. So hormones also causes osteoporosis. Next. So the neck has got two borders. This is upper border. This is upper border. Upper border is this one. Upper border. This is lower border. You have known this thing, neck. Upper and two surface, anterior surface and posterior surface. So anterior surface and posterior surface. So this you have to know experience. So description you know upper border, lower border, anterior surface. This is the anterior surface of the neck. This is posterior surface of the neck. So importance I will tell you later when we go to clinically we will go. Next. And blood supply. So blood supply of the neck is very important. You have to know the blood supply. So how to know the blood supply? So you see, the neck, how neck is supplied by blood. So profunda femoris is a branch of femoral artery. Profunda femoris is a branch of femoral artery. So neck is supplied by there is a anastomosis around the neck. Anastomosis around the neck. This is called, there are two branches. This is called, this is medial circumflex femoral artery. A branch, this is profunda femoris. This is femoral artery coming downwards. This is profunda femoris. So this is medial circumflex femoral. This is lateral circumflex femoral. A branch from lateral circumflex femoral goes this way, and a branch from the medial circumflex femoral goes this way. So they make a anastomosis around the neck. So this is outside the capsule. And the capsule of the neck, it attaches anteriorly to the capsule. All joints have got a capsule. So it is the intracapsular part. This is neck is the intracapsular part. This is attached anteriorly to the intertrochanteric line. This is intertrochanteric line. There is the neck, the capsule is attached here. And this is intertrochanteric crest. This is intertrochanteric crest. This is a ring above the bone. So these two arteries are very important when their fracture occurs. So when the child develops, there is another, you see, this is called foveal artery. It comes from here, fovea capitis, you see, round ligament of the femur. So from here, another artery comes. So here, so a neck is supplied by three groups of the, one is coming from here, another is from anastomosis. These anastomosis, they go, when they supply to the neck, from here, here. So they go above from here, and there is another plexus, subsynovial plexus of Chung, Chung, Chung. Subsynovial plexus of after inside the capsule there is synovium. So inside the synovium there is another plexus that is called subsynovial plexus of Chung, from where four sets of vessels goes. Four sets of vessels. Four sets, these are called retinicular vessels. Retinicular vessels is very important. Retinicular vessels. So one set goes from this way anteriorly here, another here, another here. So four sets. Four sets are from this surface here, anteriorly, posteriorly, inferiorly, superiorly. Four sets of vessels goes. And another comes from here, foveal artery. And some artery goes from this way to that way, that is called nutrient artery. Nutrient artery also supplies bone. Nutrient artery goes from here, shaft of the femur, from the knee, the course of the nutrient artery is like this. From the knee I flee, to the elbow I go. Means the nutrient artery is going from the knee I flee. From knee, this side, so it goes nutrient. So the lower end is the growing end. This is the how you know the growing end of a bone. Bone has got two ends, upper and lower end. Which end is growing, how you know? Both the ends are growing. Both the ends impart some role in growth of the person, longitudinal growth of a person. Femoral growth, three-fifths of the growth comes from lower end, 2/5 from the upper end. So 3/5 is the more growth occurs in the lower end, that is called growing end. So how will you know growing end? And the direction of the nutrient vessel from the knee actually. Growing end is lower end and the nutrient artery goes above. So from here also in upper limb separate. From the elbow I to the elbow I go. To the elbow. The nutrient artery goes towards this. So growing end is lower end. And the humerus, it is upper end, the growing end. Because Neutrally goes to the elbow, towards the elbow. So these are, so 4 sets of vessels goes. So these 4 sets of vessels, very important. These 4 sets of vessels takes a long time to grow. 4 to 8 years of age is the age when all the vessels are there. Foveal artery shuts down. Foveal artery shuts down. Retinal artery is growing, gradually growing. So 4 to 8 is a critical age for the children. Avascular necrosis of the femoral head is very common in case of children. In case of children, 4 to 8 years. Why 4 to 8 years? At that time, reticular artery not grown properly. It is growing, but foveal artery also decreasing. After in adult age, foveal supply is very less. Foveal supply adult very less. Reticular artery main source of energy. When there is a fracture, you know, when there is a fracture, fracture means there is a discrepancy in the alignment of the bone. This bone is fractured. So the reticular arteries are all torn. Nutrient artery also torn. Reticular artery is also torn, and nutrient vessel also torn. Going this way. So if the vessels are torn, bleeding is there inside. So inside the synovium and capsule, there will be tamponade, increased pressure because blood is there, so increased pressure. So if there is some vessels remaining, that also become compressed. Intracapsular tamponade. This is called intracapsular tamponade. So all the vascularity here, when there is a fracture here, so all the vessels will be torn. So these are, there will be no circulation. So this will not unite. This will not, there will be a problem. So this should be operated. So next I will go next time. So in the adult, the femoral fracture is very common. Neck femur in old age is very common. If there is a violent trauma, it may occur in adult age, in our age, in young age also. If the force is violent. Otherwise, don't fall from height, fall from bridge, then traffic accident, you can. But in old age, bone becomes porous. I have told you, compressive trabeculae are lost. So bone becomes osteoporotic. So even a minor trauma, like stumbling in a carpet, the old person falls and there will be breakage of the neck. Neck fracture and trochanteric fracture is very common in old age. Old age due to osteoporosis. So these are also called osteoporotic fractures. Osteoporotic fracture is very common in neck, trochanteric area, and also some other areas like lower end of the radius, that is called Pauwels fracture. Lower end of the radius is also a porous bone. So when a person falls, he tries to save himself by putting like this. This is called external expose. This way he falls. So he tries to protect himself. So there is a force comes into the lower end of the radius and lower end of the radius fractures. This is called Pauwels fracture. So here, so next slide. This is another way. Where I am showing this one. This is extracapsular arterial ring, So there will be from here, there inside there is extracapsular ring to medial circumference femoral artery. This is anterior side, medial circumference femoral artery goes. So that one we have shown the posterior side. This is the anterior side, and from there, this is called subsynovial intracapsular arterial ring. Yeah. This is called subsynovial plexus of Chung. From here, the sets of vessels goes into the head. You see, these are small things. These are vessels. This is called foveal artery. So, there is fovea capitis femoris through his. So, it is attached to here hip bone. So, cerebellum is attached here. So, this is here. So, ascending cervical artery, ascending cervical artery, these are ascending branch going this way above. And this is the femoral artery, and femoral artery branches. This is profunda femoris artery. This is profunda femoris. This is medial circumference femoral, and that is lateral circumference femoral. So these are when there is these fractures, most fractures of the fracture neck femur are displaced. When they get injury due to force of the injury, the fracture there occurs fracture and the portion is displaced. One portion goes above, another portion this way, another this way. So these are the fractures. This displays less than in intracarpal. So this is intertrochanteric fracture. Here, if there is a fracture occurs here, trochanter area, this is lesser trochanter, this is greater trochanter. So in this area also fractures occur. This is trochanteric fracture. Neck fracture, trochanteric fracture, subtrochanteric fracture here, and sharp fracture. And if there is fracture occurs lower part, this is condyles of the femur, so there occurs, this is called supracondylar fracture. Supracondylar, supra means above. So above condyles, supracondylar, this is called shaft, this is subtrochanteric fracture, this is trochanteric fracture, trochanteric area, this is neck. So head also can become fracture. So you see, so this is neck fracture. So neck fracture when occurs, there is lateral side, what are the muscles? Greater trochanteric muscles. The rotators are abductors and small rotators are attached to the greater trochanter. What are the abductors? Gluteus medius is abductor. Gluteus medius. There are how many gluteus are there? 3 gluteus. Gluteus maximus is extensor. Extensor means how it extends. This is extensor. This is extensor. Extensor. This is flexion. This is abduction. This is adduction. This is circumflexion. So you must know all the movements. And this is internal rotation. This is external rotation. So when a fracture occurs, leg becomes externally rotated. Why? Externally rotated. So gluteus medius and gluteus minimus are abductors, and other muscles, gemellus superior, piriformis, gemellus inferior, and quadratus femoris. So these muscles are also, piriformis fossa is there is a piriformis fossa here. So piriformis muscle is also attached here. Gemellus superior, gemellus inferior, piriformis, obturator externus, these are inserted in the greater trochanter. So, and the lesser trochanter muscle, what is the muscle attached to lesser trochanter? Iliopsoas. Iliacus and psoas. Iliopsoas, iliacus. So, iliopsoas, psoas is, iliacus is coming from this way. This internal surface of the iliac bone, iliacus, psoas comes from the spine, process of the vertebrae. So iliopsoas muscle is attached here, and it is a prime flexor of the knee joint, hip joint, flexor of the hip joint. So another muscle is there, flexor of the hip joint, that is called sartorius. Sartorius is attached to anterior superior axon and here and inserted into the medial side of the leg, sartorius. It is like a hockey stick like, it is attached, and semitendinosus and gracilis in the upper surface of the tibia. So flexor of the knee joint, anterior muscles are flexor, and rectus femoris is also attached to the, this is the rectus femoris, two heads. One head is attached to the inferior surface of the anterior inferior axon. This is anterior inferior axon, and this is anterior inferior axon. This is anterior superior axon. This is anterior inferior axon. So this is like this. So this is like this. So this is anterior superior. This is anterior inferior axon. So and also one head is just below above the acetabulum, rectus femoris. So these muscles are done. These deformity occurs, you see the foot is externally rotated. Here it is shown, foot is externally rotated. This is neutral rotation. Like this neutral rotation, this is external rotation. This is due to muscles. And here the muscles, these muscles pull upwards. These muscles are pulling upwards. So these muscles, flexor muscles, hamstring muscles are pulling upwards. So there will be shortening and this bone is pulled upwards. The shaft and trochanteric area is pulled upwards and head, this is the proximal part, this is the distal part. The commonest site of fracture is usually age of the patient, etiology, the postmenopausal osteoporosis. Women are most common osteoporosis. Women are most commonly affected. Osteomalacia, diabetes, stroke, alcoholism, chronic or debilitating diseases. This causes more osteoporosis. And old people and 7 to 8 decades is the fracture neck femur is very common. So fall directly onto the greater trochanter also causes fracture. Fall from height and road traffic accident very common. In case of young people, the force is more when people fall from a height or road traffic accident. Next. So next diagram. So this is called anatomical classification of fracture neck of femur. This is head. This is head. This is just below the head. This is called subcapital fracture. Just below the head, here subcapital fracture. Next, middle of the neck, transcervical, and at the base of the neck, that is called basal. A person may come with 3 types of fracture. This is called anatomical classification. So anatomical classification, next classification is, this is based on the, next one is Pauwels classification. So this is the diagram, this is called Pauwels classification. আগেরটা দেখা PAUWER, Pauwels classification. Type 1, type 2, type 3. There is a, so it is below, type 1 is 30 degree, 30 to 50 is type 2, type 3. You see, a horizontal line drawn, this horizontal line drawn along the head of the, like this, horizontal line, and next line along the fracture surface. This line is fracture surface. So this angle is 30 degree. This is called Pauwels classification, this classification. This is 30 degree, type 1, 30 to 50, type 2, type 2, type 3. Why these are important, I will tell you later on. For purpose of treatment, fracture neck femur is otherwise called unsolved fracture till now, because wherever you operate, it may unite, may not unite. It may unite because vascular union depends on your vascularity. So the neck of femur is very much avascular when it is injured, because all these sets of vessels are nutrient vessels, retronuclear vessels, even vessel from the capitis pulmonifobia round ligament, all are destroyed. So union is very less. Delayed union, non-union. Delayed union means a fracture when it does not unite within the stipulated time. For adult, generally 6 to 8 weeks or 8 weeks. And bony union occurs by 6 months. If the fracture does not unite by 6 months, that is called delayed union. If it does not unite by 9 months, that is called non-union. Non-union means a fracture is not united by, so union of the fracture depends on many factors. Number 1 is local vascularity. Vascularity is important because when union occurs, how osteoblast goes. If there is, how it goes to the local blood vessels. If there is no blood vessel, osteoblast will not go. So osteoblast will lay down new bone. So that is called callus. C-A-L-L-U-S, callus. So callus will not be formed if osteoblast is not there. So when the person becomes old, the number of osteoblasts decreases. and the bone forming cells are called osteoblasts, and bone destroying cells, bone is removed by osteoclast. So bone forming cells is osteoblast. Osteoblast does not go if there is no circulation. And second thing, if there is the good apposition, when there is a fracture, there is displacement. You have to make them united if their position is good. If it is one part is here, one part is there, it will not unite. Because apposition is very important for the osteoblast to go from this end to this end, osteoblast, through blood vessels. Third factor is infection. If there is infection, bone will not unite. Fourth one is nutrition of the patient. So if the patient is malnutrition, patient's union will be delayed. In case of femur, it is delayed because all the sets of vascles are gone. So non-union, delayed union is very common. And if the union vascularity is less, vascularity is not there, the head portion goes without any survives without any blood supply. That is called, it does not survive at all. So whenever that is called, if the local part is no blood supply, that becomes gangrenous. We tell it gangrene. It is rotten gangrene, no blood supply. But when it in base of bone, it is called avascular necrosis. Avascular necrosis. So this is the trabecular is based on the degree of valgus displacement. There are 4 types of classification. That is a very, very important classification for making any decision for treatment. Garden classification. Gardens classification is important. Next, you see gardens. You see the garden classification here trabecular bending only. That is called unicortical fracture. Unicortical fracture. There are 2 cortex. This is called medial cortex, that is lateral cortex, anterior cortex, posterior cortex. This is called medial cortex, lateral cortex, anterior cortex, posterior cortex. 4th surface, 4 cortex. Cortex is outside the area. So if there is a unicortical fracture, only one cortex is broken. So a group of trabeculae only broken. That is called type 1. Type 1 fracture. So next one is, this is called incomplete fracture. Type 1 fracture is called incomplete fracture. This is called complete fracture. Here, bicortical fracture. Both the cortex were, so both these cortex, this is called complete fracture. But there is no displacement. Here is displacement. Partial displacement. You see, some displacement is there. Regulation is there, some displacement. Here is complete displacement. So, this is called type 1, type 2, type 3, type 4. So, when a patient comes, a patient, you will see many patients come. Some patient will come to you, after fracture they are walking. They are walking. Well, sir, I have fallen down, but I can walk. There is no fracture. You tell that there is a fracture, but she tell that I have got no fracture. How can you, but I am walking, but there is some pain. So, if you do an X-ray, you may find, you may not find. You do a CT scan, you will find. Whatever it is, this is called incomplete fracture. So, incomplete fracture, if he walks more, it will become complete. From here to here. How? If he walks or she walks more. Or again, she falls down. So, incomplete fracture may go to complete. From complete fracture, type 2, it may walk more, or movement, it will go to type 3, and but gradually, without treatment, it will go to type 4. So, treatment will depend on this. If an incomplete fracture comes to you, what you will do? You ask the patient to take rest on Thomas splint. Thomas splint photo dekha. I will show you a splint. These are the splints. You see, this is Thomas splint. This is called Thomas splint. H.U. Thomas, Hugh Wayne Thomas, is the father of modern orthopedic surgery. So modern, although he is a British surgeon, he was a bone setter. So in First World War, Second World War, for the Second World War, what happened? When many people got injury, fracture shaft femur or fracture neck femur in the war field, people were lying there without any treatment. So Sir Thomas was called in how to take the patient from war field to hospital, how to carry, because it is broken, shaft also broken or neck also broken. So he designed this splint that is called Thomas splint. You see, there is a band here, outside band. This is for adjustment of the greater trochanter. So this ring goes through the thigh and adjust in the pubic region. Pubic region. This is medial side. This is lateral side. So this is the still now we use in throughout the world Thomas splint for initial treatment or initially to splint the patient to keep the limb of the Thomas splint so that he do not get any pain during shifting of the patient from this ward to that ward for X-ray or something like that. So that is called Thomas splint. He was a British bone setter. So his nephew also a famous surgeon, he is Robert Jones. They are the uncle and nephew, both are famous for their inventions. So we will carry the patient. When the patient will come, we will tell the patient to take rest on this one, Thomas splint, or we will go for operation because the patient will not obey and he will walk or she will walk. So it will go to from this to this, from this stage to that stage. So to prevent the shifting from this complication, from this fracture to complication, this one we fix. So all this fracture we have to get. But this fracture, when there is type 3 fracture, we have to reduce it. Reduce means we will put this one to this one by giving traction and rotation. So internal rotation, external rotation, and there is a image intensifier. C arm bolta, we told it C arm, we will see this photograph and we will adjust it and we will fix. So fixation is to be done within 6 hours of trauma. Fixation to be done within 6 hours. If it is not treated within 6 hours, the treatment delayed union, non-union or avascular necrosis of the femoral head will be more incidence will be more. So this way. But in old age or young age we will try to preserve the head. This one we will try to preserve the head. Whatever the age of injury. If the patient comes within 6 hours, no problem, we will keep the head. We will fix it with some screws. He will put a screw from here to here. He like this. Here also. But if the patient comes in this case or in this case, after 6 hours, after 10 days, 15 days, what we will do? We will remove the head. This head is removed. This head also removed. We will give a splint is there, that is prosthesis is there. Replacement of the head with another type of stainless steel head. That I will give you the diagram of the head. So that is called partial hip replacement. Partial hip replacement. And if we replace this portion also, acetabulum also, if the head is replaced, that is called partial replacement. If the head also removed and this acetabulum is also removed, that is called very common operation nowadays for osteoarthritis of the hip with fractured neck femur, that is called total hip replacement or THR. THR is very common treatment nowadays. These joint replacement surgeons are there. So these are there. So all the patients will come with the complaint, and a patient of old age with the history of trauma, stumbling, only minor trauma. Patient may not remember that she has fallen. The old patient will come. Sir, I have got pain in my hip. I cannot walk. If you ask, have you fallen down? Got injury? No, I did not get. Because she does not remember, or he does not remember that there was a stumble in the hip. Minor trauma. Because she was very much osteoporotic. Bone is very soft. So it was broken. So very common. Next slide. So, and the patient's leg will come. So these are the diagrams. You see, this is called unicortical fracture, type 1. Only one cortex is broken. Another cortex is all right. You see, this cortex is broken, type 1. The stage 2, you see it, total broken. You do an X-ray, that is total broken. Next, this is stage 4, 3. This is stage 3, you see, there is a gap, there is some displacement. This stage 3, this is total displacement. So, this proximal migration of the trochanter, proximal migration, trochanter has proximally migrated. This is head, so it should be here, it has migrated upwards. Proximal migration of this one occurs when the patients are coming to hospital neglected, and this is due to the, how it goes above, due to pull of the abductors, short rotators and abductors. Rotators rotate and abductors pulling in. So this one is pulled by abductors, and there will be, and after long time she will keep like this. So there will be flexion and contracture of the flexion of the knee joint will be like this. So flexion and contracture of the knee joint. So many complications will arise. Next slide. So I have shown you all the. So this is another orthopedic trauma association classification, not needed for you. Next slide. So mechanism. You see mechanism injury, I told you, low energy trauma, most common in older patients. Direct fall from the greater trochanter, valgus infection. Also indirect trauma, muscle forces overwhelmed with strength of the femoral neck. So low energy trauma, direct trauma, indirect trauma, or high energy trauma. These are the way of mechanism of injury. Next. Next. High energy trauma accounts for the femoral neck fractures, both younger and older. High energy trauma means falling from road traffic accident, falling from bridge, falling from tree, like that. Next, and next, cyclical loading stress fracture. What do you mean by stress fracture? Stress fracture means repeated stresses causes fracture. Like BSF recruiting or military recruiting. They are the complete military athletes, military recruits, ballet dancers who are ballet dancers or dancing. You have got no habit of dancing. So you dance for half an hour, all right. But a new dancer dances always without any, today half an hour, next day half an hour, 1 hour, like that. So there will be stress on the bone, stress fracture. Very, very common fracture in the metatarsal. Because Mars fracture, this is called MARCH, Mars fracture in case of army recruits. Newly army recruit, when they come, so they have to do march, like the left-right march and miles. So they get Mars fracture. Or it common in the tibial shin, stress fracture, very common. So stress fracture causes pain during rest, night time, there is mass pain. So they cannot end. So in case of osteoporosis fracture bone is weakened, so repeated trauma causing fracture is called stress fracture. Repeated trauma. Next. So clinical presentation is like that, fall from height, I told you, non-ambulatory. Any patient, as for example, a hemiplegic patient has got cardiovascular attack, hemiplegia, one side paralysis or paralysis, they are ambulant, non-ambulatory patient is not walking or doing exercise or lying down for a long time. That is the cause of osteoporosis also. Long time bedridden causes osteoporosis. Osteoporosis not only deteriorate. So a bedridden patient, whenever an old patient comes, we do, now previously we used to give it by giving traction or keeping rest. Nowadays I would tell no rest. So operation first day, second day, third day you walk. Because if you sit, if you take rest for a long time, there are many complications. Lying down for a long time. Number one, osteoporosis. Number two, urinary tract infection. Number three, thromboembolism, DVT, deep vein thrombosis. Number four is basal pneumonia. So these are complications in the case of ambulatory, non-ambulatory patient. Non-ambulatory, ambulatory means these are walking. So non-ambulatory means lying down in the bed. So sometimes বলে না আমি 7 দিন 10 days 11 days 15 days or 1 month rest, you take rest for 3 months. So patient will have osteoporosis, patient will have urinary tract infection, patient will have basal pneumonia. So these are common complications of and deep vein thrombosis. Deep vein thrombosis in the leg. So next. So you see, this is the condition of this leg is like this. This is rotation like this. Why? This is short rotators are rotating the leg like this. So these are like this. So full external rotation will occur if the leg is, if the fracture is extracapsular. Extracapsular means here is the fracture, here is the line where capsule is at all. If the fracture is here, the rotation will be less. External rotation will be there, but it will be less. But here is the extracapsular fracture, so here is a fracture, so it will fully externally rotated. Because these external rotators, short external rotator, obturator external, gemella superior, inferior, piriformis, these will cause external rotation of the lower part. Lower part will be external, fully external rotation, because they will take overaction on the full external. But here there is a external rotation will be there, but it is not full. Full means the lateral side of the leg fully lying on the blade, helplessly lying like that. But in case of neck femur, it will be half. Trochanteric fracture occurs a bit earlier age than neck femur. Neck femur occurs 7th, 8th, trochanteric 6th, 6 to 7. So trochanteric fracture is very. So clinical evaluation how? So pain will be evident. Then you will see how in hip motion. You do external, if patient comes, you rotate the patient. So rotation will cause pain. Any disease in the hip joint, most important is rotation. You do rotation, hip. How to examine the hip joint? The আপনার hip joint pain, whether you have got a pain, the disease in the hip joint or otherwise. So exclude the disease in the hip joint. As for example, how to know that shoulder is not any joint? So this is one movement, this is another movement, this is abduction. So shoulder is free. But sometimes patient will come, sir, I have got pain here, sir, but disease is here, cervical spine. That is called referred pain here. Referred pain, from here, the pain radiates over here through the nerve roots. So we get pain in the shoulder area, C5 right root, C5, cervical 5 nerve root pain in the shoulder area. This is supplied by deltoid nerve to deltoid. So that area is called regimental base area, and the nerve supply is C5, 6. So C5 is a pain, but patient will tell, sir, I have got pain here, but I don't have pain here. You ask, is there any pain here? No, sir, I have got pain here. So then you see the what movement, whether shoulder joint she is saying. So first examine the shoulder, abduction, this is abduction, flexion, extension, this is medial rotation, this is lateral rotation. So everything is free. So it means there is some disease here. So clinically you must be strong. Otherwise you have to do X-ray of this, everything. Patient who has got 300 rupees, she can do only one X-ray, only one. So you have to do only one X-ray. And by seeing only one X-ray or one dissection with less money, you have to diagnose. So you must be clinically very strong. There are many doctors at a time, less experience. So they will know, you do X-ray of the neck, X-ray of this, everything. Then you do MRI. So if you are clinically very strong, so you need not do so many investigations. Previously in our time, our teachers used to do very less investigation. Nowadays nobody touches the patient. You have to touch. The patient, you have to see the patient clinically examined, then only you can come to a clinical diagnosis and you are a good clinician. Neck femur and fracture shut femur is today is our topic. Neck femur is very important, especially because of its complications. Number one complication of fracture neck femur is AVN, avascular necrosis of the femoral head area. Only head will become necrosed. And avascular necrosis will occur and patient cannot walk. And the treatment of avascular necrosis is replacement of the head. Either total replacement of the head, if the patient is very old, above 60, we will replace the head as well as we will replace the acetabulum. And plastic socket is there or a stainless steel socket. We will put the acetabulum with screw, fixed with the screw. As here you will remove it, we will give screw, and here also we will remove, we will give a new head. So this is total replacement. If it is patient is old with fracture and avascular necrosis. The common complication is non-union. The fracture will not unite because there is no vascularity. So patient comes earlier, you treat earlier. The earlier the patient comes, this is better. But in our country, many in village area, they will go to quack. So quack will do some treatment, so they will come late. So you have to prepare. So there are many types of operations and many research about this one. So when the patient comes earlier, we will fix it with screws. From here, we will put screws like this. Here, we will make hole here. Small, by drill, we will make a hole and put the screw up to this much. 3 screws or 4 screws, plus neck for neck femur. So, trochanteric fracture, if there is a fracture here, we will make a screw here up to this much screw and give a plate here, small plate, fix it. Because if we do not give and we will give here, will be a screw and they will take rest for 1.5 months. But she can walk with non-weight bearing. Without any weight bearing, with crutch, she or he can walk. Here also he can walk non-weight bearing because ambulation is very important. Ambulation is very important for prevention of prolonged immobility, like complications. Prolonged immobility complications means osteoporosis, urinary tract infection, basal pneumonia, DVT. To prevent this complication, we want to make the patient mobile very hard. So these, and we have to give a plate over here, 3 hole, 4 hole. This is called dynamic hip screw. Nowadays, we are not opening the fracture area. This fracture area you cannot open, may not open. You see there is a camera is there and there is TV camera, TV is there. So you put the patient on the TV camera and you see the photograph like this and operate on seeing this, you can put the screws. Need not open. Here also nail is available, long nails. We put here we drill by seeing the photograph only. We need not cut. Here only we will small incision cut will give and we will put here drill hole and put the rod here, then screw by seeing the photograph. X-ray. By seeing the X-ray. Patient will be there seeing, but by seeing the X-ray only will do. So no need to open the fracture. Next, total or diagnosis. So where diagnosis, you see diagnosis is evident when the complete fracture is there, total fracture is there, you diagnosis is evident by their history and also diagnosis made by history and also by clinical findings and confirmed by X-rays. X-ray will confirm. So stress fracture will be difficult to fracture, undisplaced fracture, impacted fracture may be difficult to visualize on plain X-ray. I told you earlier that when the unicortical fracture or stress fracture you cannot see. At that time we take the help of CT scan, computed tomographic X-ray. So CT scan we do. Next, multiple fracture. Patient may come with fracture neck, fracture shaft, fracture pelvic bone, multiple fracture. So commonly occurs in road traffic accident or as for example train accident. So you will have multiple fracture from this area, that area, multiple fracture. This is called multiple fracture. Is called otherwise called polytrauma. Polytrauma. Polytrauma is a common case. So polytrauma means one big bone, both major injury like liver, kidney, major organ is injured along with a big bone like shaft femur, neck femur. So, so like that. So multiple fracture. Next. So radiography X-ray is done by two positions. One position is X-ray epi view, keeping the leg like this, putting the X-ray film like this, plate below. So X-ray epi view, and also we go internal rotational view and lateral view. So internal rotational view, when you do internal rotational view, it will be more evident. So the anterior posterior view of the both pelvis, if internal rotational view, I told you, internal rotational view and cross table lateral view is very important. Board scan also we can perform, but we are not doing now here. Magnetic imaging, these are very costly tests, not needed nowadays. Next. So, next. Next. So, the importance of a true epi position. You see, this is epi position, this is epi, anterior posterior view, true epi position, you see, and this is called leg internally rotated view. So, when you do internally rotated view, you are seeing incomplete fracture. Here, next, you see, there are some X-rays I am showing you. There is a fracture here. This is a basal fracture. The neck was absorbed. Completely long patient came later, very late. So neck absorbed. This is also fracture, total fracture, neck absorbed. Next. Next. So here is another fracture, neck. You see proximal migration, the head, this portion, lower fragment migrated proximally, then neck, this is transcervical basal fracture. This is called transcervical basal. This exam, neck, this is neck is here, pura neck, this is basal fracture. This is proximal. Patient came late, so after neglected fracture, this is proximally migrated. This is another fracture X-ray of this one fracture. Next. So there is another fracture here. There is a fracture here. You cervical fracture. You see, it is no displacement. It is grade 2. Total fracture is there. Type 2, garden type 2. This is garden completely displaced. Garden type 4. Next. So this is cross leg table. How to take an X-ray? Cross table. Next. So raised knee and covering a tube angle. So tube you have to put the tube plate below and tube here. And next. Next. You know Shanton's line? Next. You see, this is called Shanton's line. This you see a line. If a fracture is not there, a line draw from this one, from this end to this end, this is Shanton's line. If the line is broken, means you see there is a fracture, it will displace upwards, or anyway this central line will be broken. So this is a feature you can see in X-ray. So একদম আগে আগে দেখ, this is central line, very important. আগের X-ray গুলো দেখা, next আগের X-ray, previous X-ray, another, and our again, you see this central line is broken. This central line, if you draw from here, it is broken here. Central line broken. Central line is broken. You see, you draw from here, central line is not there. So central line is very important for X-ray diagnosis. Next. Next. So goal of treatment to minimize the patient discomfort, restore the hip function, and these are the goal. Why to treat patient discomfort and pain and hip restored so that she can walk. Next, rapid mobilization is very important. Rapid mobilization. Next, impacted garden. Next. So you see that article. Next. So yeah, you see there is we are putting like that. Rod, you see, these are drills. We are making drill. You drill is making, and we are putting the 3 screws. 3 screws. Garden screw is there. Garden screw, and we are putting it. Next. So this is called espinel. It is not used nowadays. It was in our time when we are students. We used to use this one. No, espinel is not used. Multiple capsular screw is now most commonly used nowadays. This Smith Patterson nail, espinel is not used, and this is espinel not used. Dynamic hip screw we are using, especially for like that plate also we are using, dynamic screw and plate, that is for trochanteric fracture. Next. So this is called 2 types of that is called Austin-Moore prosthesis. You see Austin-Moore prosthesis. When completely head, we remove the head, we will put it into the shaft of the bone, shaft of the femur, and this is head. We will remove the head and put it. So patient will walk by 3 days, 34 days. Next. So indication for hemiarthroplasty. Hemiarthroplasty means removal of the head, only head, not of the cerebellum will not remove. Cerebellum you remove is total hip. So total hip arthroplasty we are doing. So these are the comminuted displaced fracture femoral head, pathological fracture, poor medical conditions, because it takes very less time, 45 minutes. 45 minutes you can remove, and we can do this one. Next, fracture shaft femur top hole. Next. So weight bearing to be full weight bearing to eliminate the non-union. There will be, if you remove the head, there is no chance of non-union, no avascular necrosis, nothing is there. So it is a very safe operation for very old person, so non-ambulatory person. So it will take very less time, 45 minutes, and non-union everything will live. Comminuted displaced fracture. Which ছেড়ে দে এটা? This is you see. দেখা. Next, this is Austin-Moore prosthesis. We have removed the head and put it here, and patient can walk. But here is normal head. There is, you see, there is small cyst. So this is called osteoarthritis. This is an old person, and old person is there, osteoarthritis is there. This is called cyst of the bone, subarticular cyst is there. So next. So total replacement where I go, osteoarthritis, rheumatoid arthritis, where I will do total replacement of the cerebellum as well as the head. Next, no need. This is called total. So this is called total. Here we have removed the cerebellum and neck also. Everything we have removed. So the previous one you show, previous one. This is called total hip. You see the total hip. This is called partial hip. Hemiarthroplasty. The cerebellum is not removed. Cerebellum is normal. You see, cerebellum is normal, and only head is removed. Next, last time, this is cerebellum removed, and also head also removed. very common operation nowadays. And if a person becomes orthopedic surgeon, you have to do it. Every day you will earn 3 lakhs, 4 lakhs. Every day. Each operation, minimum 50,000 surgeon charge. Minimum 50,000. So, next. So, femur. Oh, these are the complications. Complications will be the many complications. You need not worry. But if you long time, bed sore will be there. If the patient lies long time, bed sore, pneumonia, I told you, pulmonary embolism, deep vein thrombosis, these are very, and avascular necrosis, non-union, very common complication of I told earlier also. The longest bone of the body, surrounded by largest mass of muscles. Anterolateral bowing is there. Isthmus is the region of the femur with smallest intramedullary isthmus. Isthmus is this portion. This portion is isthmus. The medullary canal diameter is very less here, isthmus. So when we ream the bone, it is very difficult to ream, putting the nail. You see. So all are shown here. So before in diagram also here you see gluteal tuberosity. Here, so pectineal line, and this is called linea aspera, medial supracondylar ridge, medial side linea aspera, medial side and lateral side. This is medial side, lateral side. This is medial side. So these are. And next, rough crest of the bone running down the middle third of the bone. So linea aspera describing, everybody knows it. This is linea aspera. So muscles are attached here. Next. So abductors, so muscles you have to know. For fracture shaft to understand, you have to know the muscle pull. Muscles, abductors, they abduct the hip joint and are mainly gluteus medius and minimus. I told you earlier also, iliopsoas is the flexor. So to remember, you have to read, at least revise every week once. Every Saturday and Sunday is the time you have to revise. Anatomy, morning, physiology, evening, and night, after 10 o'clock to 2 o'clock, you have to revise the biochemistry. Difficult part last, you will sleep. Biochemistry is the most difficult thing. For me, I know, I do not know over you. So I used to read the latter part so that I will sleep and I will not remember anything. So in statistics earlier. So you revise, otherwise you cannot remember. So whatever you read on Monday, you will forget on Saturday. So you revise. So regularly revision, at least one book you have to revise 7 times. So only then only you become. There is nothing to do. 5 years you have to struggle. 5 years you struggle, then you become MBBS. 2 years, 3 years again, less struggle. Then again less struggle, DM. Then you have become a complete doctor. So most important thing is this, the relaxation comes after 12 years, 13 years. So there is no relaxation for 5 years. No relaxation, no cinema, no bioscope, nothing. So the adductors, you see adductors are the muscles on the medial side. So adductors are, what are the adductors? Adductor longus, brevis and magnus. Magnus means big. So adductor magnus is the imaginary, and longus, magnus, brevis. Brevis means small. Brevis means small. So they strong, so fascia lata is on the lateral part, and tensor fascia lata is lateral part is there, and if it becomes the deep fascia of the thigh. Next. See compartment. So anterior compartment, medial compartment, posterior compartment. So posterior compartment muscle is biceps femoris, semitendinosus, semimembranosus, and these are the portion of the hamstring muscle of the adductor magnus, posterior compartment. So the hamstring muscle has got flexion of the knee joint, and also in the medial compartment, basically these are the adductors, and these are the anterior compartment quadriceps muscle. Quadriceps means forehead, quadriceps. So forehead means, what are the muscles? Quadriceps muscle, you know. Barsum medialis, lateralis, intermedius, and rectus femoris. They are inserted in the upper part of the tibia with a band, and that goes to the tibial tuberosity again, patellar tendon. So iliopsoas iliopsoas is the flexor, sartorius is a double flexor. Double flexor, why? It is called trailing muscle also. So why? It flexes the hip joint as well as the knee joint. Yeah, pectineus, femoral artery, vein, nerve. So these are, you have to remember anatomy. Sir will teach you much better than me. Then next slide. So this is supplied by profound femoral artery, the branch of the femoral artery, all the nutrient vessel also enter posteriorly along the diaspora nutrient vessel. It goes from the knee fluid, nutrient goes to above nutrient artery, and there is some perforating arteries. So a vessel, so periosteal vessels also enters along the diaspora. So there are periosteum has got two layers. One is fibrous layer, fibrous layer is outside. So so periosteum has got, and this one most important thing in the femoral neck. Another thing, the periosteum has got two layers. One is cellular layer, one is fibrous layer. The cellular layer is absent. In femoral neck, the cellular layer is absent. So that is very important because of non-union. Because it causes non-union. There is no cellular layer. So how do you know? Periosteum is a main source of cells for union. If there is no periosteum, no union. So the cellular layer of periosteum, or it is otherwise called cambium layer. Cambium layer of periosteum or cellular layer of periosteum is absent in the neck of femur, but it is present everywhere. Only fibrous layer is there. Fibrous layer is for, so like pleura, periosteum, two layers. Everything has got two layers. Inner cellular layer, outer fibrous layer. So these are the, and there are perforating arteries. When we operate openly by cutting the shaft, perforating artery also lost. So when the femur is very vascular bone. So whenever there is a fracture shaft of femur, shaft I told you here subtrochanter area, this you see, this is shaft. So this is subtrochanter, lesser trochanter, greater trochanter, subtrochanter, this shaft. So there are so many, so huge muscle attachment is there. So muscular vessels, periosteal vessels, all vessels supply. So huge loss of blood. So when a patient comes to you, patient may have shock. Shock means, what do you mean by shock? Patient will come unconscious, shock, pulse will be feeble, not pulsable. Whether cold come is sweat. So, and main organs of the body, the important organs like brain, heart, kidney, liver, these will not get enough blood. So, because more blood, this is shock due to loss of blood. 1 liter to 1.5 liter of blood is lost in case of femoral fracture, and 2 to 2.5 liter blood lost when pelvic bone is fractured. 2 to 2.5 liter blood is lost when pelvic fracture. Patient will come in shock. So at that time we have to give profuse amount of crystalloid. Crystalloid means saline we will give, saline, and so normal saline we will give huge amount of normal saline, and even we have to give blood transfusion. So compartment I told, artery also, blood supply, outer third of the cortex periosteal vessels, inner two-thirds by endosteal vessels, endosteal vessels by nutrient vessels. Endosteal vessel comes from nutrient vessels. So when there is a fracture, the nutrient vessels, endosteal vessels are disrupted. This endosteal supply is disrupted. Periosteal vessels also lost, and medullary vessels restored late in healing process. Next, trauma. High energy trauma, normally in old age, first to osteoporotic bone, there will be pathological fracture. So pathological fracture, high energy trauma, means road traffic accident, high speed accident, motor vehicle accident, very common motorcycle accident. This is the common cause of injury. Next. So pathological for elderly patient inconsistent with degree of trauma, the patient may have cancerous, secondary deposits, there is primary cancer somewhere like stomach or somewhere there is a deposit here. Secondary metastasis, it is called metastasis. So secondary or there may be osteoporosis. The common cause is osteoporosis or secondary or primary bone tumor. So these are the causes. So what are the types of fracture? Next slide. As you see. So this is transverse fracture. You see transverse fracture. Transverse means like this, single bone. This is a called comminuted fracture, but this is called a butterfly fragment. This is called butterfly fragment. This is also butterfly fragment. Comminuted fracture. This is called incus tension classification. Grade 1, this one, grade 2, grade 3, grade 4. This is comminuted fracture, multiple pieces, 1 piece, 2 piece, 3 piece, 4 piece, 5 piece, like that, multiple. This is a bone, a segment of bone is lost. This is up. So this is incus tension classification. Ageta, next, problem slide, next, again. So, how to diagnose AB view, lateral view of the femur, and whenever you do an X-ray, the joint above and joint below should include the X-ray. When you advise, like advise X-ray of femur, X-ray of, don't write femur, X-ray of thigh, AB, lateral view, AB view, lateral view, anterior posterior view, lateral view, with hip and knee joint. Joint above, joint below should be included. Then this should be like AB view with the pelvis, it's a CT indication. So type 1 is no comminution, I told you. Type 2 significant amount of comminution, type 2 more than 50% cortical contact. Type 3 less than 50% cortical contact. Type 4 is segmental fracture, no cortical contact, you see. Type 4, no cortical contact. Significant comminution, you see, there is type 3. There is 50%, 50%. Less than 50%, 50%, less than 50%. There is, this contact is not there. Only a small portion is contact. There is more than 50%, less than 50%. There is no cortical contact. A segment of bone is lost. So a patient will come, history of trauma, patient may have shock. So patient will have shock, shock I told. Pain, unable to walk, and whenever you move the bone, patient cannot move the bone, there will be abdominal mobility, loss of transcendental mobility, swelling of the thigh, deformity will be there. Broken deformity, bony crepitus, abdominal mobility, loss of transcendental movement. Loss of transcendental movement means when you move from here to here, if you push it, you can feel it here. Put one hand here, you can feel that your thrust is going here. But when it is broken, thrust will not go. This is called loss of transcendental movement. So associated injuries means femoral fracture one side, femoral fracture along with neck fracture. So another fracture is the bilateral femoral fracture, both the sides fracture. So both the sides fracture, patient will have 3 liters blood loss. Very difficult, very dangerous patient. So ipsilateral tibial shaft, on one side femur fracture, again tibial shaft or acetabular fracture. So there are many combination and permutation. So take how it occurs, few bending force, rotational injuries, oblique, these are important for reduction. So if you know the type of fracture and also is how it occurs, the rotational force, then only you can reduce it under image. Nowadays, previously we have to open the fracture. Like this, we have to cut here, open it and put some rod and other. Nowadays we are not opening. We are putting the rod from above, small incision. And under image we are seeing and putting the rods and no incision. Under image, then local anesthesia cannot be done, spinal anesthesia. Spinal anesthesia is given, spinal anesthesia 90 up, 90 up. 90 up. Learn spinal anesthesia.
There is some contraindication of spinal anesthesia. Then what?
General anesthesia. So 90 years only GOK. GOK means God only knows. And if he is not fit, medically fit, child operation you cannot do. So there is one term is there, GOK. God only knows. So you go like that. So unfit patient anesthetically you cannot go for. But common operation is done by spinal. Spinal is a type of local operation, So small incision we give and we are operating. You see, there are huge swelling and there is deformity. Deformity, there is a broken, here there is a fracture. This is mid-shaft fracture. So, mid-shaft fracture, what we will do? We will give an incision here. If you know the fracture, we will give traction. Somebody will traction, will give assistant. We will put a rod from here. One guide wire passing through this. We will put this by this way movement, blind movement under image. We will see X-ray plane. We will see and put this on. Give a rod. Finish. And next day he will walk. So first, when a patient comes, you have to see the ATLS cause, advanced trauma guideline. How you research it? You have to see the airway first. Whether when a patient comes to the emergency with multiple injury, you have to see airway is the advanced trauma life support. Advanced trauma life support guidelines. First you see the patient whether he is breathing or not, airway or not. Now this one airway is intact or not. Next is breathing. You see whether he is breathing or she is breathing or not. Pulse you see, pressure you take. Or, these are called, and these are called evaluation of the patient. You see normally 500 to 1000 milliliter of blood is lost. So present with shock. I told you 1 to 1.5 liter. And volume replacement by fluids or blood transfusion if required. And you have to do a catheterization. Catheterization to know the urine output. Because when there is a shock, urine output will be less and kidney will also shut down. Gradually, kidney also will fail. And it treated by 3 ways. Number 1, if there is a wound, outside wound, you cannot put rod just now. You cannot. You have to, patient will be admitted. You have to replenish the circular blood. You see the hemoglobin. If the hemoglobin is less than 10, surgery, anesthesia will not be given. Evaluate the patient by doing all the blood tests. Give blood for if there is less blood, hemoglobin is less. Or replenish the shock and fix with Thomas splint. Thomas splint, I have shown you Thomas splint, put the limb in Thomas splint, keep for them, make the patient fit for anesthesia. After anesthesia, if there is no wound, we have to debride the wound, clean the wound, dressing the wound, and bone to be fixed by external fixator. There is fixator is there, diagram is there, I will show you. And we have put rod from outside, fix. And then only you can, if you fix the bone, then only you can do dressing. Otherwise, every day you open and movement is there and patient will try and there is no, without fixation of the bone is fast, then dressing the wound. And the wound heals up, then you go for definitive surgery. Like you can put a plate, screw, or you can put a rod, intramedullary nail. Rod is called intramedullary nail. So, Kunshar was the person, father of intramedullary nailing. Kunshar, he is a German surgeon. So, Kunshar started the nailing of femur. So, application of knee, you see. So, patient comes here. So, we will give a traction like this, Thomas splint. We will give a traction. Stabilize should be done at the emergency room. When the patient comes in the emergency room, we give a traction, stabilize it. Otherwise, carrying the patient to the ward will be difficult. Number 1, patient will be crying with pain, very painful. So, long leg. So, in case of pediatric age group, below 5 years, we give a traction for 3 weeks. I have shown you traction for 3 weeks, then a hip spica. Hip spica means a bandage of plaster. You see there is a fracture on the right side. We will give a plaster from hip joint to full pelvis to hip, this one, full leg, and here half leg. Here half leg. When you will go to final year or third year, you will see if patient comes over here, I will show you how hip spica is done for pediatric age group. But for operation, for adult, operation is a must for femur. Operation is a must if the patient is fit for anesthesia. If he is not fit, then only is okay, God only knows. So, your nails are different type, elastic nails are there. So, after skeletal maturity, antegrade intermedullary nailing, you see, these are elastic nails. Elastic nails. So, there was a fracture here, shaft femur. So, we will make a hole here, medial side, lateral side, small hole, and put the nail like this. So, there is gone. These are elastic nails, elastic band. So, this will go by a image C-arm, under C-arm guideline. So, this is called interlocking nail of the femur. This is most modern operation. This is most modern. So, we will make a hole here. In the trochanter area, we will make a hole, put a guide wire, a small wire or there, guide wires, then put the nail, and we will give a screw like this. This is a screw like this. So, these screws are given, otherwise it will rotate. The bone will rotate. So, to prevent the rotation, we give the screws. You see, two types. It is a older method. Nowadays, two screws are this way. These screws are given not, these are transverse screws, you see, transverse, from lateral to medial, lateral to medial, lateral to medial. But nowadays, another type of nail is there. So, we will give one like this, one anteroposterior. Anteroposterior. One would be like this, another is like this. Upper one is like this, lower one is like this. There are holes like that. So that no rotation will take place. So, retrograde nailing means from the below, nailing, from below. So, here we put the nails, retrograde nailing. This is antegrade nailing. From here, antegrade nailing. So, whatever, but C-arm is a must. Without C-arm, you cannot do. External fixation, open reduction and internal fixation. So, external fixation is done, conversion, maintaining with 3 ways. So, in compound fracture, external fixation is done. Compound fracture. Compound means open fracture. When there is a wound, we have to take care of the wound, then external. So, indications, the open reduction, internal fixation, we play it. These are the indications. There is no need to know all the things for you. X-ray pictures of different patients. I will show you some pattern of fracture. So, you see, this is a transverse fracture, and this is Thomas splint. This is Thomas splint. Patient came, Thomas splint. This is transverse fracture. You see, transverse. This is spiral fracture, spiral, by rotational force. This is called spiral fracture. Spiral fracture occurs by rotational force. Rotational force. Rotational force means like this, rotational force. So, this is transverse fracture by bending force, rotational force. This is also transverse fracture along with a small fragment. This is one fragment, this is one, and there is another fragment here. You see, there is comminuted fracture, you see. So, here Thomas splint is not given, here this is lower third. This is upper third, this is lower third fracture, lower part of the fracture. So, lower part, this is fracture the upper third. This is upper third transverse. This is middle third. This is upper third. Yes, upper third. This is another fracture, you see. This is subtrochanter fracture, below the trochanter. So, these are not photographs, these are X-ray. Patient was there. So, these are real picture of a patient. These are real picture. This is subtrochanteric fracture. This is one fragment. This is another fragment. This is another fragment. So subtrochanteric fracture, upper third fracture, spiral fracture, upper third fracture. So it is lower third fracture, lower fourth. You see, this is comminuted fracture, multiple pieces. On the Thomas splint. This is Thomas splint. There is no Thomas splint, these two patients. So there is also, you see, fracture femur. This is upper third, this is mid third, fracture mid third. Along with this fracture is there, multiple. There is a fracture here. This is fibular fracture, this is tibia fracture. This is tibia fracture, this is fibular fracture. So this is called supracondylar fracture. You see, the fracture is here. The treatment modality of this will be different than the treatment of this one. So the implant, treatment means operation you have to do. Operation is to do. This is called distal femoral plate. Distal femoral plate is there. We have to write here distal femoral plate, or we have to put here a rod. Here distal femoral nail. Yes, sir. So these are again. This is one and this. These are supracondylar fracture. Supracondylar fracture femur, this is complication of this and these two are ipsilateral femur and tibia. Ipsilateral means same side, contralateral means opposite side. Thank you.